Hey everyone, welcome back. Today we are joined again by Dr. Stenehjem to give our weekly update to the community about what's been going on with COVID-19. Eddie, thanks for joining us. We really appreciate it.
You got it.
So as always, I want to talk about numbers first. Our total case counts in the system or in Utah as of yesterday's data was 27,356. We have a total of 205 deaths and we've had 1,700 hospitalizations. Yesterday's case counts was 610. And I know you're going to talk a little bit about what you think for today, since that information isn't out there yet. But Eddie, let's talk about how hospitals are doing and case counts.
Yeah, if we look at the epi curves, what we're seeing is a distinct trend up. We thought maybe, last week we saw a leveling of counts, but 2 days ago they reported a case counts of over 700. Yesterday they counted 610, and today I anticipate our number to be north of 800. In terms of positive tests here within the Intermountain system, we hit an all-time high yesterday, and that's likely going to equate to likely the highest case count we've seen on a daily basis across the state. So I suspect today will be above 800. What we're starting to see is likely the impact of the July 4th holiday in terms of rising case counts. July 4th holiday started last Friday. Typically the incubation period is anywhere between 5 and 14 days. And then you start getting your test turned positive. So this Friday, we're 7 days out from the beginning of the holiday. We're likely going to start seeing increased case counts throughout the weekend. Continuing this upward trajectory of positive cases. In terms of hospitals, how are we doing? We currently have about 155 patients admitted to our facilities across the system. If we look at our referral centers, so our referral centers are the big hospitals, McKay, Utah Valley, Intermountain Medical Center, the hospitals where we send patients to for higher level care. If we look at ICU capacity there, we're at about 79%. That's pretty high. And so once we get to 80 to 85% capacity, that's when things start getting real tricky. You have to have a number of beds available for emergent cases, for that stroke, for the heart attack, for the trauma victim, to be able to come in and immediately fill that bed. So once we get above 85% in terms of ICU beds, we start getting into a really significant pinch. And really what that is an indicator for us to start activating our surge plans in our hospitals to open up more space, open up more beds to take care of COVID-19 patients. So we're actually on a pretty scary course right now. Right now, we can take care of the patients and provide them the care that we've come to expect. But as those numbers go up, as the capacities go up, as we start activating our surge plans, we're going to be calling on clinicians, so physicians, doctors, advanced practice providers, nurse practitioners, PAs, pharmacists, respiratory techs, every caregiver, to start filling into new roles, roles that we've done just-in-time training for, but not necessarily roles that we've trained them for, that they've spent their life training for. And so when we get to that spot, it's going to be a real challenge on us to be able to provide the care that we want to be able to provide for our patients.
I know we did a press conference earlier today with the Utah Hospital Association. That was actually something you guys mentioned, that don't really look at the number of hospital beds, but look at the number of people who care for them. Where we could run out of hospital beds, but we could very much so run out of people who could care for those people. And if that happens, we're in a very bad situation. So I think that's something important to keep in mind.
I love the quote that Dr. Bresacker gave that said, hospital beds don't care for patients. Physicians and our caregivers care for patients, and critical care physicians, critical care nurses, our pharmacists, our infectious disease pharmacists, those aren't people that we can just go and clone. They are a finite resource for us. And so once we get to a point where we are asking the acute care hospital physicians to step in and take care of ICU patients, and the ICU docs to supervise those physicians, that gets to be a very different situation. A critical care physician goes through 4 years of med school, then 3 years of residency, and then another 3 years of fellowship, and then comes out and is a critical care physician. That's not something we can replicate in the 6 months that we had to prepare for this pandemic.
Yeah, I think that's a very good consideration, that training and people's medical backgrounds are very important for this pandemic. A lot of questions that we've been getting to are around the death rates between the flu and COVID, and why we keep focusing on COVID-19 if the flu kills more people yearly than what we're seeing right now. That, and then also if COVID has such a high rate of survival, why are we so scared of it? Can you talk to those two fronts really quickly?
Love to. So your statement about flu killing more people each year than COVID couldn't be farther from the truth. That is an absolutely wrong statement. So influenza is terrible. So I don't want to downplay influenza. Influenza can be a very, very severe disease, can cause death of young people, old people, the like. Typically in the United States, the mortality for influenza is between 20,000 and 60,000 people. And that's with a vaccine, and that's with therapeutics. Okay, and so 20 to 60,000 people die each year from influenza, really depending on what's the circulating strain, how effective is our vaccine, et cetera. And that is in a 12-month period. Okay, so that's 20 to 60,000 people in a 12-month period. So far right now in the United States, we've had 133,000 deaths from COVID-19. And that really is in a 3-month period, April, May, and June. Okay, we had very few people in March, really started to tick up. April, May, and June, we've had 133,000 deaths. And it's in a community, being the United States community, the global community, that's never seen this virus, has no immunity. We don't have a vaccine, and we don't have effective, widely available therapeutics. And so if we continue this trend, if we continue the trend that we're currently on with 133,000 deaths in the United States, and if you look at the curves, continues to go up, that number will easily double, if not triple, if we don't change anything, because we've got a long ways to go and we've got a respiratory viral illness season coming up here shortly.
Yeah, the death rate is really interesting too. The curve of the United States. I think yesterday was the highest case count across the United States with 62,000 cases nationwide, which is a large number of cases. And I think a lot of it can be contributed to the fact that the July 4th weekend, you said, is starting to take into account. That was actually going to be one of the questions I was going to ask of you, is when do you think we'll start to see those? And you think today we'll start to see those case counts being reflected?
Typically, with this virus, what we see is an incubation period between 5 days and 14 days. So once you get exposed and infected, you don't start showing symptoms for 5 to 14 days. And so let's just say, hypothetically, you were out at a party on Saturday on the July 4th weekend. 7 days go by, you start getting symptoms, then you go get it and tested, and then it takes some time to get that test resulted. So another potentially 2 days. So you're looking at 9 days from when you got exposed and got infected. And so we actually may not see, peak case counts due to the July 4th holiday until next week. And we'll probably continue to see those cases increase over the next probably 7 to 10 days. That'll give us a really good idea of how effective this virus was transmitted through our communities, through our populations, through the July 4th holiday. And then keep in mind, Amanda, but also keep in mind that it then takes another 5 to 7 days after those tests reported for those people to get hospitalized. And so typically what happens is that they get tested, they're positive, and then it takes another 5 to 7 days for them to clinically worsen, for them to go seek care in a hospital. And so the hospitalization data lags even further behind the testing data. And so we probably will continue to see the impact of July 4th on our hospitalizations probably in 2 to 3 weeks. And so it is a significant lag that we just are ready for and anticipate.
Yeah, that lag is super important, especially the hospitalizations, and then the deaths have even more of a lag too. You're not going to see all these numbers go up at the same time, because it's cases first, then the hospitalizations, then the deaths. And I think that's something that when you're looking at the state's data, please take that into consideration, that they're not all the same. The case counts are not reporting all of a sudden the hospitalizations that same day. So that's just something important to think about.
Yeah,
On
and
the press conference,
the
sorry, go ahead.
the death stuff is hard too, because what we've seen is, the death count isn't rapidly increasing here in Utah. But again, keep in mind that there will be a delay from a death count of a number of weeks. And so most times when we see the deaths here within Intermountain, these people come in, they get on the ventilator, and they're on the ventilator for a long period of time. And then finally they succumb to their illness. And so many times that death doesn't come until weeks after the patient gets admitted to the hospital. And I think we also have to realize too, if you look at what's happening in terms of who's getting infected in Utah, we are seeing a decrease in the average age of those getting infected. And so what that means to us is that we're having more and more younger people get infected who still get sick and still have to require the hospital and the intensive care unit. We have a number of patients in our hospitals right now that are under the age of 40, and a number of them are in the intensive care unit on a ventilator. And so we're getting more people that are younger, that are less likely to die, but very well could have complications that require a hospital. And I think the other thing is we're getting better at taking care of these patients. We're now using advanced therapeutics. We have a drug called remdesivir. We're using convalescent plasma and steroids. These are things that have been shown to be effective, and we're using them in most of our patients.
Yeah, that age range is very important, especially for my generation. I am in that generation of age that thinks that they're immune to this for some reason. But yeah, I think it's important to note that. I want to talk a little bit about the questions that were asked during the press conference earlier today. We're just going to reiterate a couple of things that were asked. For one, the governor mandated masks yesterday for students kindergarten through 12th grade. They will be required for school in the fall. Why is it so important for children to wear masks? There's apparently not a lot of data around them getting sick or passing away from this, but why is it so important for them to wear masks?
Yeah, so there's a number of things that go into this. And, as it was stated on the press conference today, I wish we knew more. I wish we had more data, more history with this virus as it pertained to school. We just don't. And so why is it important for kids to wear masks is a very good question. One, it's to protect the teachers. So we have a lot of teachers that are in front of all of these children, educating these kids, and we need to make sure that our workforce of teachers, many of them are in high risk categories, remain safe. Okay, so that's one. Two is that many of these children, all of these children, go home, and many times they're going home to families, potentially large families, that have older people in the home and that are at high risk. And so if we have transmission amongst children and then they go to home and then transmit it to their parents, to their grandparents, then you can obviously see how this can just perpetuate itself and lead to more cases in the really sensitive populations that can cause severe disease. And I think also it shouldn't be understated, there are kids that get severe disease from this multi-inflammatory systemic disease. This MISC is really something that is evolving and that we're keeping a close eye on this. So not all kids do well with this virus, and we certainly don't want to put them at risk.
And there's been a lot of conversations too about how we teach our kids to wear a mask. And I think a lot of it has to do and come down to the guardian of the child. If you're having someone go back to school in the fall, it's up to you to teach them the importance of wearing a mask. Maybe start every day wearing it for 5 minutes, 10 minutes, build that up and teach them that they're doing this to protect others. Of course, they might have moments where they take it down or do something wrong, and don't scold them for that, but teach them what the proper way is to wear a mask. And it's not the teacher's responsibility to do that. It's really the guardian and the parent's responsibility to start teaching them now. We have a month until school starts, and that can really help. And the other important point you brought up about teachers, there's also janitorial staff. There's custodians that come in. There's food workers that work in the schools. It's not just the kids. So you're masking your child up, not just for the child, but for every single other person that works in the school. And I think that's really important to consider as well.
We realize that this is going to be really hard, and that it starts with modeling the behavior at home and showing them what it means to wear a mask and helping them through that process. And let's be honest, kids are not going to wear a mask perfectly. Let's not let perfect be the enemy of good here. We understand and we certainly appreciate that kids aren't going to wear a mask 100% of the time. They're going to take it off. They're going to trade. They're going to fling it around the room. We get it. But at the same time, we have to try. And we know that even if we can get to 80%, 60%, 70% effective kind of mask wearing, that's great. And that's much, much better than zero. And so, yes, we understand that kids are not going to wear these perfectly. Yes, we understand it's going to be hard, and we're going to rely on guardians and parents to model that behavior and teach that behavior. And we're going to do the best we can.
So I want to ask a couple more questions from the press conference earlier today. Another one was, what do we know about airborne transmission in the virus? How long can droplets linger in the air after we sneeze, cough, yawn, etc.?
Yeah. So we're going to get a little technical here. So if you look at the distinction between airborne and droplet, that distinction was made for the hospital. Okay, so there's certain viruses and bacteria that are airborne, meaning they live and they can hang out in the air and infect people very easily. So a perfect example of that is measles. Measles is one of the most infectious virus we have. It's transmitted from a respiratory standpoint, and it can linger in the air and cause airborne transmission. And so when we think about the measles, what's called the R naught, which is how many people get infected from one infected person, the R naught is 10 for measles. It's an incredibly, incredibly contagious infection, okay, because it hangs in the air. The reason why that's important is that in the hospital, we base our personal protective equipment on the characteristic of that virus. And so in the hospital, we put those people in airborne precautions, and we wear N95 masks or full respirators. Okay. Other viruses like influenza virus and other respiratory viruses are called droplet precautions or droplet transmission, where that virus is transmitted on big droplet particles that come out of your mouth and fall down, okay, within 6 feet or so. Those people, you don't have that same risk as you do with measles, and there what's called that R naught is much lower. It's less than 2. And in those people, we're much safer to go in with just a surgical mask because they don't linger in the air. Okay, so that distinction came from the hospital, and that's it. So can influenza, can coronavirus become aerosolized? I mean, can it hang in the environment longer than in general? Sure, it can, but it's really in distinct time periods. And so it's when people that have this infection are getting procedures like a bronchoscopy, or they're getting intubated and you're getting aerosolization of those secretions, that the virus can hang in the air. But in general, in the public, that's not happening. And the transmission there is respiratory. It's droplet precautions of droplet transmission. And so, yes, there's times where you can have airborne transmission, but in the communities, in the public, that is very, very less likely. And it's most likely just standard respiratory droplet, where a standard face covering surgical mask would be effective in prevention. Sorry, that was a long-winded answer.
Nope, it was good. I think it's important to talk about data and get technical. It helps people really understand the full picture. Follow-up question to that as well. We've had a couple people ask us, what about your eyes? Since your eyes are not protected, you're wearing just a mask. What are your chances of getting COVID-19 via your eyes?
Great question. And the true honest answer is we don't know. So in the hospital, in our healthcare workers and our caregivers, when we care for patients, whether they've got COVID or not COVID, right now in this environment, we're wearing face masks and eye protection. Okay, so we're all wearing face shields or goggles in addition to a surgical mask because of the potential transmission, through the mucous membranes of your eye. You're much more likely to get it infected through your nose or your mouth, we think, but there is a potential that you could with the eye. In order for that to happen, is you're going to have a direct exposure of somebody coughing or sneezing into your eyeballs. And so we think that the biggest risk of transmission is through the respiratory tract, which is where that virus lives. So in terms of excreting it, it's on your face, it's on your nose, it's in your mouth. You don't excrete the virus from your eyes. And so that's why we don't cover it in public, and we cover our nose and our mouth, is because we're preventing that virus from coming from us into the community. And that's the point of wearing those face coverings. You're not leaking virus from your eyeballs.
A great point. I want to talk about masks really quickly too. So Salt Lake County and Summit County, another couple counties throughout the state, mandated masks. I think the date was June 28th. Don't quote me on that. But you mentioned earlier that we could see a decrease potentially in case counts after about 2 weeks, which I calculated is July 12th. So this upcoming Sunday. If we don't see decreases in case counts, is that because masks don't work, or is that because people aren't wearing
them? Yes. So it's most likely going to be because people aren't wearing them, and that we had a big holiday, July 4th and 5th. I can just tell you, when I came into work, I drove through Murray Park, and I didn't see hardly anybody wearing a mask, and we're in Salt Lake County. And so we definitely see pockets of people using masks in grocery stores, et cetera, but we're also seeing plenty of people not wearing masks. And so it's going to be pretty hard to tease that out, especially given the fact that there was a big holiday, right after we mandated masks. But I think we're going to need to see some more mask compliance in the community for us to really see any kind of meaningful reduction.
So maybe around August 1st or so, that would be about a month, we can start to see something. You mentioned driving through Murray Park, and someone on the live actually asked a question about outside. Mm-hmm. And if they're running or participating in an outdoor activity, should they be wearing a mask or do they not have to?
Great. Really good question. So we got to think about what are the things that lead to transmission. Okay. So one is the infectivity of the person that has the virus. Do they have a high level virus? Do they have a low level virus? Where are they in that period? You also have to think about the time exposed to somebody with COVID-19. And so people that spend a lot of time with somebody with COVID-19 has a much higher risk than somebody who has a very short time with somebody with COVID-19. So take, for example, running. Okay, if you're running in a park, on a trail, you're running by yourself, and you pass somebody going the opposite direction, the time you've come in contact with their cloud of respiratory secretions is incredibly small. And so the ability to get infected from that person is very, very minimal. In addition, you're outside, so you've got all of this air to dilute out the virus. And so when you are out running and exercising, especially if you're by yourself, as long as you're maintaining, 6 feet of distance and you're quickly moving past each other, the chance of transmission is very, very low. But that being said, if you're outside in a group close together and you're not abiding by that 6 foot distancing, you're going to want to wear a mask. And so family picnics, when you're not eating and you're really close together, yeah, you're going to want to mask up. But if you're exercising by yourself, that's not a time to wear a mask. And if you're exercising with somebody, you really want to try to have some distance apart so you can allow that virus to get diluted out through the atmosphere.
So if you're walking with a group of people, wear a mask.
Yeah, especially if you're not 6 feet apart.
Another question for you is about asymptomatic spread. There's been a lot of conversations about whether we have any further evidence about people who are asymptomatic actually spreading the virus, which was why masking became such a topic, because you could not know you're carrying COVID-19 and then expose someone to it. Do we have any further information or evidence about asymptomatic spreading at all?
So let's keep in mind there's two populations we need to think about. Those that are truly asymptomatically infected and don't go on to get symptomatic disease. And then there's those people that are what are called pre-symptomatic, meaning they're currently asymptomatic, but tomorrow they start developing cough, sore throat, shortness of breath. Okay, so there's asymptomatic and pre-symptomatic people. We definitely know that those people can transmit the virus to other people and they can go on and get sick. And so really good data published in the medical literature that has shown this. The CDC says up to 40% of transmission can be due to those people that are either asymptomatic or pre-symptomatic. Okay, and so wearing a mask when you're in the public protects you from putting that virus out into the community and infecting other people, either before you generate symptoms or if you just are asymptomatic and the virus will run its course. And so right now, the best guess of data is approximately 40%. We've had other estimates to say 20 to 30%, but that's our best guess based on the medical literature. and wearing a mask would really reduce that burden of disease that you're contributing to the transmission. The challenge with this virus, Amanda, is contrast it with the original SARS-CoV-1 virus. This is the virus that circulated in 2002, 2003 in China, then came to Toronto. In that virus, people were at the peak of their transmission, the peak of their infectiousness after they've had symptoms for approximately 5 days. So when they first develop symptoms, they're not very contagious, and you can go ahead and isolate them. And then when they peak on their 5 days of symptoms, you can really control the spread. Okay, that's ideal for a respiratory virus, is that you're not infectious until after symptoms develop. Contrast that with SARS-CoV-2, this coronavirus. You're at your peak of transmissibility, your peak of infectiousness, likely 48 hours before you generate symptoms. And so the time where you're most likely to transmit the virus is actually when you're asymptomatic. And so that's clearly the time where you need to have that face covering on, or just be at home and not engaging with other people.
I think hopefully that will help clear up some of the confusion about asymptomatic. I'm going to take a couple questions from the Facebook Live really quick, and I don't know if you can answer this, but someone asked if we're having a shortage of tests at all, and I do believe the answer to that is no, but do you know any further evidence of that, if that's the case?
Yeah, so right now we're able to test people that have symptoms, and we're also doing some asymptomatic testing of people that are coming in for surgery. However, as the community spread increases, as the number of cases increases, that's going to increase the number of people that need to be tested. And that's going to increase the burden that is going to be put in on our testing systems. So as of right now, yes, we have the capability to test anybody that needs testing. That being said, if we get really significant spread, and we're now, instead of having to test between 5,000 and 7,000 people a day, if we now have to start testing 7, 8, 9, 10,000 people a day, that's going to put a real strain on our testing supplies. And we'll likely have to reconsider how we're going to do this to ensure that we're testing the people that need it most. Part of that could be, not testing pre-surgical patients or turning surgeries back off to really decrease the amount of tests. All of that's on the table. And it really is dependent on how we as a community kind of react to this and decrease the curve.
Along those lines too, someone just asked how soon after exposure is testing recommended as well?
Yeah, great. So we are really recommending people that are only getting tested if they have symptoms. Okay, so if you've got a high risk exposure to something that's known to have COVID-19, you'll likely develop symptoms in 5 to 14 days if you got infected. And we want you to come in once you have symptoms, because once you know, then you can go and you can self-isolate. Okay, and so you can prevent the spread. So we definitely want you to get in and get tested at this point. There are some people that have high risk exposures, particularly healthcare workers, that we are testing them at around day 7 to see if they're carrying the virus.
And it does look like, by the way, that the state just released their numbers. It was 867, if I can read correctly. So highest single case count so far. So I think that's really important to remember, people, that the numbers are going up. They're not going away. And I know I asked our testing team this before we started our live today, that our average since July 1st has been 3,163 tests for the Intermountain healthcare system. So we're not seeing this super huge increase of testing happening. We're staying pretty average around that 3,200 number. So again, the tests are not the case counts are not increasing because our testing is going through the roof. So that's important to remember. Someone else also asked a question. They said that they have a lower immune system. They would like to know if they should wear an N95 mask when they actually go to the hospital, or if a surgical mask will be sufficient enough for if they have to have a visit or anything like that.
Yeah, really thoughtful question. So an N95 mask is a mask that is much thicker than a surgical mask, and it has a much tighter fit to the wearer's face. And so when you have an N95 mask, you actually have to go through what's called fit testing. You have to make sure that mask actually fits the shape of your face. And that's a procedure that we do in the hospital. It takes about 15 minutes. We are using N95s in the hospital when we care for COVID-19 patients that are undergoing aerosolizing procedures. And so there are people that are undergoing bronchoscopies where you put a tube down the throat to get cultures or whatever it might be, or when they're getting intubated. Anytime we're having aerosol generating procedures, we're wearing N95 because we're protecting that from, getting infected to the healthcare worker via aerosolization. Otherwise, we're taking care of our patients on the floors that are stable, et cetera, with just a regular surgical mask, because we feel a surgical mask, based on the data that we have, is protective. And we have very few healthcare workers getting infected from their patients. And so if worn appropriately, and if somebody is immunocompromised or immunosuppressed, the recommendation is to wear a surgical mask if one is available to you. We really need to focus. N95 masks are really for those times where you have aerosolization of the virus. And most times that's going to be overkill in the community or just in the regular hospital environment. But in those people, a surgical mask would be ideal.
Okay, a few more questions for you. So this has to go along with the asymptomatic versus pre-symptomatic. Someone said if you are the most infectious at those states, why wouldn't you test shortly after exposure?
Yeah, so keep in mind, you're going to get exposed, and there's a really good chance you're not going to get infected. Okay, and so we want to make sure we're being stewards of our testing supply. And so if we are doing asymptomatic testing of the masses, we would run through our testing supplies in no time. And so that's one thing. It's one, that you're potentially not infected. And two, if we did that, we would completely run out of supplies. This is the whole reason why we need to ensure people abide by physical distancing, decrease the amount of close contacts, and wear a mask. If we do those things, we will decrease spread from those that are pre-symptomatic or asymptomatic.
Last update for us. Will you just give us a quick update on vaccinations and therapeutics and how that's going along? Someone specifically asked about the supply of Remdesivir. Am I saying that correctly?
Yeah.
That we have, and kind of just giving us an update since last week. Are we any closer to getting a vaccine for this?
Yeah, so the vaccine world is rapidly evolving. There are 2 or 3 vaccine candidates that are entering phase 3 trial or have entered them already. And so people may have heard of the University of Oxford vaccine, which is also supported by AstraZeneca. That has started phase 3 studies, meaning these big, large efficacy trials. So these are the trials where you figure out whether or not the vaccine works in terms of preventing the disease or decreasing the severity of the disease. Those studies launched in Brazil, in South Africa, and in the UK. We don't think there's any US-based sites for that AstraZeneca trial at this time. The Moderna study, the one sponsored by the National Institutes of Health, that is slated to start by the end of July. It was supposed to start this week. They had some delays, unclear the reason why, but they anticipate starting by the end of July. And then I think Pfizer and some other companies are not far behind from starting their phase 3 trials as well. And then we've got about another 8 or so candidates that are a little farther behind and are most likely to start phase 3 trials later this fall into winter. The FDA put out guidance in terms of what it would take to get emergency use authorization of a vaccine. And it's going to require at least 6 months of data and likely over 30,000 people in the trial. Okay, so even if we started that vaccine trial today, we're looking at that vaccine trial finishing likely in end of December, early January. And then it's a matter of production and distribution. Many of these big companies are placing pretty significant bets that their vaccine will work. And so what they're doing is they're actually, in parallel with their clinical trial, they're developing their manufacturing arm. And so AstraZeneca is making this vaccine that they're studying currently in Brazil, South Africa, and UK. And if it gets passed by the FDA that is effective, then they would be ready to be able to do distribution almost immediately. But if the vaccine doesn't work, well, then they just wasted this incredible, manufacturing ability to make a vaccine that doesn't work. And so a number of the big companies, and that's what this Operation Warp Speed is all about from the US government, is that they are making some bets that these are going to work and developing manufacturing along the lines with the testing of the vaccine, in the hope that once we find a vaccine that works, you can start distributing. And then keep in mind, we're not going to have enough vaccine to give everybody on the globe a vaccination. It's going to take a while for them to ramp up, vaccine production to do that. And so most likely we will be going through a process, which will likely be controlled either from FDA or CDC, about who gets vaccinated, who are the high risk people that should get vaccinated, and how does that look and how does that work? And so we're already thinking about within Intermountain, what does a vaccine strategy look like when one is available? On the therapeutic side, remdesivir is an antiviral drug that we have data, pretty decent data to show that it has improved the care of patients with COVID-19. It decreased their time of illness, and then there's new data coming out that it potentially decreases mortality. The challenge is we don't have a lot of that. And so Gilead, the maker of it, has turned over the supply to the US, and then it's been allocated to the states. And then it's up to the states to allocate it. And they've allocated it then to the healthcare networks based on how many patients they have. And so right now within Intermountain Healthcare, we have criteria for remdesivir, and we have it, and we're giving it to patients that are most critically ill that would utilize it or benefit from it the most. And currently our supply is still looking like we've got enough for at least the next couple of weeks. It comes in on a rolling basis, and so we're not really sure how long that supply is going to last, and whether or not we'll be able to get more from Gilead. We have other medications that we're also using, so convalescent plasma, taking the plasma of people that have recovered from this and giving it to people that are currently sick. We are doing that often, and we're actually the #2 center in the US in terms of utilization of that. And then we're also incorporating steroids or dexamethasone. The big recovery trial that was published a couple of weeks ago, we've reviewed that and we've identified patients that it likely would benefit. And so we're also using dexamethasone as well. And we also have a host of clinical trials that are running in parallel to all this as well. So it's a very active area for us. And we're really proud of what our therapeutics committee has done. It's led by Dr. Webb and Dr. Brown. And it's just a testament to the infrastructure and the research that they've set up.
Okay, one more question. It's about herd immunity. Sorry, we could talk for hours. There's lots of questions on here. So if you're watching and we're not getting to your questions, we will go back and answer them afterwards. But I want to talk about herd immunity really quickly. Someone specifically said, what do you say to those who believe in herd immunity? They say that the more people that are exposed to the virus, the weaker that it becomes, or the harder it is for someone to get sick. Can you make a comment about herd immunity in general and how far away we are from that?
So what is herd immunity in general? Herd immunity is when you get a majority of a population that has protective antibodies to a virus or an infection. So if a virus were to enter a community, there isn't enough people that are susceptible that it would then propagate into an epidemic. Okay. And so you need a number of people, you need a set number of people that are susceptible to a virus to be able to transmit it to get expanded growth. Okay. So once you hit herd immunity, it means that there's enough vaccinated people, there's enough people that have protective immunity that it won't spread like an epidemic. Okay. That's what herd immunity is. Typically that occurs when approximately between 55 and 80% of a community is immune to an infection. Okay. And that immunity could potentially be defined by an antibody. It could be defined by a different lab test, and it could also be generated by a vaccine, not necessarily just getting the infection. And so the way we right now can assess what percentage of the population has been infected with SARS-CoV-2 is through antibody tests. And so the University of Utah with the Utah Department of Health did a study called the HERO study. They just did a press release on it on July 2nd. So if you Google HERO study, University of Utah, you'll find the press release. They show that 1% of the Utah population, which is a 4-county population surrounding Salt Lake County, had antibodies to SARS-CoV-2, 1%. Keep in mind, you have to get to 55 to 80% to have herd immunity. And so if we allowed the community to have rampant spread of this virus to get to that herd immunity status, we could do that. But what would happen is you'd have thousands of people would die, not necessarily from the virus, but from other things that needs high level ICU care, but they can't get that care because all of our hospitals are full with COVID-19. And so we have too big of a susceptible community to us go into herd immunity without overtaxing our healthcare system and not being available and willing, not being available to care for patients that need care. And so really, if we want to protect the infrastructure of our community to be able to take care of your parents, your friends, your neighbors, we got to slow the virus down. And the only way we can do that without a vaccine or a therapeutic is through public policy measures. And that is physical distancing, wearing a mask, and washing your hands. It's not sexy, it's not glamorous, but it's tried and true, and that's what we have available to us.
That's a great place to end. Like I said, if you're watching and we didn't get to your questions, we'll go back and answer them. Eddie, thank you so much for joining us and giving us your time. A couple of phone numbers really quick for you guys. If you have questions about COVID-19 or would like to get screened and tested, our COVID-19 hotline is still available. You can call that phone number at 844-442-5224. We also have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. And like Dr. Stenehjem said, please wear a mask in public, wash your hands, and we can hopefully stop the spread. Eddie, thank you so much for joining us, and we'll talk to you guys next time.